in adults with anorexia nervosa, we have no known effective treatments. The studies that have been done have really been equivocal in terms of outcomes, and there are no evidence-based treatments. So if we are not effective with kids, we are, at this time, really limited as to what we can expect to be able to do if someone becomes chronically ill with anorexia nervosa and has it in adulthood. And which is, for all the good reasons we want to treat kids anyway, but that's another compelling reason. When the approach was developed at the Maudsley Hospital in the 80s, it was a time of clinical innovation and forward thinking by Christopher Dare and Yvonne Eisler, amongst others. Christopher Dare is a child psychiatrist and family therapist and child psychoanalyst. Yvonne Eisler is a family therapist, a child psychologist, and really interested in systems and family systems. And so they brought all this complex clinical experience and wisdom to thinking about how to do this approach. They were pretty skeptical when Daniel and I approached them about writing a manual for this treatment. There was a notion that maybe that would be inferior clinical care, potentially, and too cookbookish. And I was American, and that was already kind of a rebellious notion to begin with. Daniel had actually trained there. Anyway, they did agree to help us with it, with some hesitation. When we were writing the manual, we had to figure out how to structure the treatment in a way that could be written about. And one of the things that we did was really lay out the fundamental principles or assumptions that underlie the approach. And the more we have worked with this, these fundamental ideas, which were all present in the descriptions that Yvonne Eisler and Chris Dare had written, though, when we actually parsed them out and began to actually see how they played out as lines within the therapy, the more central they became to how we organized our own thinking about the manual. So when I talk now about these fundamental assumptions, the thing I want you to take from this is, if I follow these fundamental assumptions, that's going to be more important than the specifics of any particular intervention. So keeping to these core assumptions will really help guide everything you do in the more specific way you say things and do in a session. So that's why we're spending time on it. And so that wasn't really the case when there wasn't a manual before. You really couldn't see that. There are other advantages to manuals too, but I'll save that for later. These are the 5 fundamental assumptions: an agnostic view as to the cause of the disorder, a non-authoritarian stance as a therapist, a strategy of empowering parents and families as a whole, the use and importance of separation of the child from the illness of anorexia nervosa using externalization strategies, and a very pragmatic, solution-focused, symptom-focused approach, particularly in the beginning. So what does it mean to be agnostic? So an agnostic is, well, what do you think? What is an agnostic?
So whether you can begin from the previous slide?
Mm-hmm.
Okay, thank you.
From the previous slide. You mean to start all those again?
You can start like on point 5 if you want.
Oh, okay. So it's important also that we take a pragmatic stance in terms of a focus on the initial symptoms and that being the core strategy for starting the treatment. So what does it mean to be agnostic? Does anyone know when I say the word agnostic, what comes to mind?
Religion.
If you could raise your hand, and then the
Religious beliefs.
religious
At some level.
beliefs. So what kind of religious beliefs?
About the existence of God.
Yes. So an agnostic tends not to take a stand on that, right? Whereas an atheist takes a stand, right? And a believer has a stance too. So the agnostic is somebody who doesn't take a stand. That doesn't mean that she or he does not believe in anything, nor that they believe in something. They just are not prepared at that time to take a stance. Now, just for the moment here, those of you who have treated cases of anorexia nervosa, and there's 7 or 8 or 9 of you that raised your hands, what was the cause of the anorexia nervosa in the patients that you treated? Any of you can answer that? No. Raise your hand if you know. Daniel, do you know?
No.
No. And so that's oh, you d-
No, just depending on the case, yeah, there was not one cause.
okay.
Yeah.
I haven't treated anorexia per se, but a lot of eating disorders that I have seen, it's a lot stemming from abuse growing up, their lack of control in their home environment.
So that's I'm glad. So that's one of the hypothesized causes.
Correct.
There are many hypothesized causes, and we're going to come to this problem in a minute.
Nice.
But the data supporting that isn't really very compelling. Meaning, yes, people who are abused sometimes develop eating disorders, but they mostly develop other kinds of problems. So there's nothing specific about that cause. And that's important because anorexia nervosa is a very specific kind of problem. It's not distress. It is a very specific set of behaviors and cognitions. The other thing that you mentioned, which is another theory about control, is a very interesting one too, because the idea here is that there's a theory that by having anorexia nervosa, you're going to feel more in control of things that you otherwise don't. There's very little evidence that that's true. It's a strongly held theoretical idea, but it hasn't really been studied. So one of the reasons that someone might be agnostic, and the reason I'm agnostic, is because I don't want to be saying to someone, this is the cause, if I don't know it is. Now, why might that be important? If I act as if I know the cause, and I think it's because you've abused your kids, or you're an intrusive, hyper-controlling mom, or you're a neglectful, distant dad, I'm blaming you. I am blaming you. Now, have any of you ever been blamed for anything? Maybe. It's not a very pleasant experience to be blamed, especially if you didn't do it. Has that ever happened, that you've been blamed for something you really didn't do? And sometimes people will believe that you did it because you were in the vicinity. But really the cat knocked over the milk, not you. But the cat's long gone. What do you mean the cat knocked over the milk? The cat's outside. Well, when you blame people, you affect their state of mind in terms of their confidence and feelings of self-efficacy. So if you blame people, you're going to increase guilt. You're going to actually make them less effective, potentially, in making changes they need to because they believe you, because after all, you're a professional and know what you're doing. So if you say, I probably caused this, maybe I did, well, if I caused this, what is it that how can I possibly help? I'm a big mess already. I've already created a problem. I'm just going to make it worse. And this is what parents think. And they find abundant evidence that that's true or believed in the literature. And yet, in fact, the evidence about parental causation of eating disorders and anorexia specifically is extremely compromised data, meaning it's only in the situation where the kid's already sick that you already are seeing changes in the family, or there's a historical event that someone connects up, but if you actually look statistically at these things, they don't hold. And one of the things I was trained to do as a therapist, maybe you were trained differently, was to think pathologically. I don't mean that my thoughts were pathological, they might have been, but I was taught to look for problems. What's wrong with that kid or those parents or that family that this is happening? I was really taught to organize my thinking from a formula point of view, developing formulations, as here are the problems in that family, and this led to this, that's this. And it was a really fun kind of thing to learn to do as a training therapist. But most of it, as a scientist, I have to say, was pure speculation. Now, this approach doesn't really support that idea. Because if you don't know the cause of something and you act in therapy as if you do, how many have done that? Actually, you've got a hypothesis. I think about a lot of formulation as finger pointing. Like they did it. This is something like that, and it's a pathologizing process, which in this treatment is not helpful. Now, I'm not talking about other kinds of treatment. In this treatment, it leads to problems of decreased self-efficacy in the parents and guilt and conflicts that will make it harder for the family to use the resources it has. The other thing that we get so fascinated by, or at least certainly I know I was trained, was to think about etiology and cause. It's so brazen of us in psychology and psychiatry to do that because we don't really know the cause of any psychiatric illness. We always resort to this multifactorial, environmental, genetic, stress kind of hypothesis kind of business, but we really don't know. But I would also point out to you that we shouldn't feel too terribly bad about that because in medicine in general, we don't know the causes of many, many things, and still we have effective treatments. For a simple example, maybe relevant to the Miami area, skin cancer, we don't treat, when someone gets skin cancer, we do not treat the skin cancer because the sun caused it. We cut it out. The treatment has nothing to do with the cause. Now, prevention, different matter, but the treatment itself, surgical treatment, you do not cut out the sun. That won't cure the cancer. You have to actually cut out the lesion. If you have high blood pressure, many, many things can cause high blood pressure, but most of the medicines you take are going to be treating the symptom, not the cause. And that's true so we shouldn't feel so bad that we are going to have a symptom-focused therapy. It's not a failure that we don't address the cause. But you will find, or I find, that families have bought into, I don't know if it's what we've sold in terms of psychologists and psychiatrists, or that you have to get at the root cause in order to get this problem solved. If we had to get the root cause of skin cancer, we'd have to live on Neptune or something. This treatment does not target trying to get at the cause.
What happens if you have a parent or guardian that has an eating disorder, and maybe specifically anorexia nervosa, or tends to be very, very critical of the adolescent's body image, weight, nutrition, is just very, very critical of them, and they feel like they're always under this microscope. Would that, I mean, again, like you say, we're not looking at etiology, we're going to focus on treatment, but how might that affect this also? Because that parent now is the one that's going to be in control of that first phase.
Yes.
How would that affect it?
Yes, it's a great question, and I'll answer it now. We get more into some of this later, but there's two parts to the question, and I want to take them separately. One, if a parent has an eating disorder, how does that affect treatment, particularly in a general way? And then the second question has to do with particular kinds of vigilance around weight and shape and critical comments about those things. So let's take the first one, where you actually have an eating disorder, a parent with a history of an eating disorder or an active eating disorder. First thing I would sort of remind us is that there is substantial evidence that there would be an increased likelihood of there being an eating disorder somewhere in the family, about 5 times the rates of eating disorders running in families, about 5 times expected rates compared to others. So that's not something you would find to be atypical, so you might find it. You also find that to be true, by the way, for depression at a different rate, or anxiety disorders and things like this. And we, for some reason, don't think quite the same way, I would argue, that parents who are depressed or have had a history of depression are somehow going to be really bad parents. Or that they cause the depression and things like this. And I want to remind us of that, because this really kind of cultural belief that we've held on to with eating disorders is very damaging. That is, that parents cause them. Now, do you remember that mothers cause autism? They do. Because of refrigerator mothers, they cause it, right? You all agree? No, we've stopped that one. Do you remember that parents cause schizophrenia too, because they give double binding messages? Bateson? You remember that? Yeah. So that you all agree? No. Because you've learned better. We have not learned better with eating disorders, and we should learn better, because the evidence isn't there, just like it wasn't there for these other problems. Hence, we need to be agnostic, we'll go back to the slide, about that. There are some really long-standing theories and beliefs that are very hard to change about this. The second part about this is, I would argue that in the eating disorder world, certainly the world that where as a clinician I work, we have a fair number, about a quarter of the clinicians have had a history of an eating disorder themselves. And we do not exclude them from treating kids with eating disorders. Now, are they so different? Because they have a history? Is it because they have a professional title? I'm not sure. So I don't assume that because someone has had a history of an eating disorder that they cannot be helpful. In fact, many parents who have had an eating disorder are really knowledgeable. They're the first ones to pick up on the problem, and they are really clear on, they have a resource that other parents don't have, because they get it. Just like a depressed parent might well pick up on a depression in their adolescent much more quickly than someone who'd never had any knowledge about depression, or a parent with OCD or anxiety disorder might really notice anxious behaviors too. So there can be important skills and or resources that come from this. Now, in clinical cases, I've had families where there's been a history of an eating disorder that's been really helpful, and I have had other cases where it has really interfered. You don't know until you start, and then you'll have to deal with what it means. Sometimes it means that parent can't do certain things, and it may mean the whole treatment won't work very well. And as we've tried to emphasize repeatedly, we know this doesn't work for everybody. It's not every family can do it, and not every kid can do it. Critical comments and vigilance over weight and shape. This is actually one of the motivating ideas behind doing separated family therapy that Daniel described, comparing conjoint and whole family therapy versus separated family therapy. And the idea there is that highly critical families, in the context of doing therapy together, would create a hazardous and non-helpful environment for the child in the therapy, and that you could work on that really directly in a more separated format. When Daniel and I wrote the manual, we knew that data a little bit from studies that he had done at the Mosley with his doctoral work. So we built in thinking about minimizing critical comments and helping families think about their impacts. So that's part of what we do in the manual. It doesn't mean we're always successful. And I have to just say, sometimes I'm surprised. I'm a Midwesterner, so I have a very low critical comment kind of threshold. Other cultural groups have much higher levels, which are acceptable. And I'm often overwhelmed at a session. I think, whoa, that was just full of dark comment, and but it just goes away. It's not a big part of what they're experiencing. I had a family, an Israeli family, American-Israeli family, and they would just yell at each other constantly, saying what I thought were pretty abrasive things. They did a great job, and they loved each other through all of that, and it was just totally acceptable to them. Now, I'm not saying that's true of all Israelis or of American Israeli families, but that particular family was a real lesson to me that my own bar was set low, and that I might estimate critical comments in some instances. On the other hand, the studies that have been done on average families with anorexia suggest very low bars do actually make it important to attend to critical comments. Even less one or two in an hour session might be sufficient. Also, in the therapy itself, we would try and help the parents with those behaviors. If you say, well, that parent makes these critical comments and they don't, they're making all these weight and shape kinds of worries, so they shouldn't be there. Well, how's that going to help? They're still going to be made. So if instead you can help growth and understanding take place and learning. I like this really simple-minded way of thinking. Therapy is learning. I mean, we can put a lot of highfalutin kinds of names on it, but therapy fundamentally is learning. I mean, it's learning. And there's a lot of different ways to learn, and we know that in therapy people learn in a lot of different ways. But you cannot learn if you're not there. Okay. Did I answer your questions? Good. All right. I like questions. I really do. It's a workshop. It's the reason why you're here and I'm not just in a sound booth. How do you maintain agnosticism as a therapist? And I try to think about this when I'm doing FBT or any kind of therapy a lot of times when I don't, even when I'm not doing FBT. So I actively just tell my do not pathologize. Jim, don't pathologize. Don't pathologize. Even if there is some pathology, work with it. As Daniel said, yet let ye who has no sins throw the first stone, or whatever, something like that. Do you have anyone in here? I'm sure you're all from perfect families. Mm-hmm. And you work with their imperfections on a day-to-day basis. The second injunction is practice forgetting. This sounds like sort of Zen-like dialectical behavior therapy kind of thing. But what you think you know. Because a lot of times when you actually really examine what you're saying, you go, do I really know that? Where did that come from? What's really in there? So I do remind everyone I train, and I'm lucky to be in an institution that I have really nice opportunities for training and teaching. Really? Are we sure of that? Let's really think again. Do not theorize. This is very hard for people trained in psychodynamic psychotherapies particularly, because that's really mostly what you do. And so this is not a psychodynamic psychotherapy. Do not theorize. Work with what's in front of you. And believe me, there's enough in front of you that you don't have to be doing any theory. You're going to see, and hopefully we'll be able to illustrate in a way, some of the things that families present you with, and you'll say, oh, well, I don't really need to get into the theory. I can see those parents aren't agreeing. That's not a theory. They're not. Or I can see that that child is really not going to be helpful with this right now because, look, she's completely avoiding saying anything. So you don't have to be doing a lot of theory. Daniel said this, and I'm going to reiterate it. Work with and encourage strengths, not weaknesses. And all of us have families that confuse us when we work with them. For whatever reason, families, one family or another, might make us less clear about what we're seeing and doing. And therefore, if we see ourselves tending towards blaming and pathologizing, get some supervision, talk to someone, because the chances are good that somebody else may not be as affected in the same way as you might be, and you might get your vision cleared up a bit on this. If there is pathology, abuse, neglect, things like this, you do need to act on it. This is not a therapy that says ignore that kind of thing at all. So I want you to be clear about that too. Another, are any physicians in here? Any MDs? I'm the only one. Oh my God. I'm sorry. It's hard for physicians. I was just talking to Daniel about this in the cab right here from the hotel, and I was saying, you're talking about our teams, and we're talking about pediatricians, and I said, oh, the hard thing about pediatricians is they think they own the patient and they want to tell them what to do. And that's a problem with family-based treatment, because when you think you own your patient, you tend to get overprotective and you tend to interfere with things. And if you start telling them what to do, that's going to make it very hard for them to feel like they own what's happening. And there's all kinds of problems with that. However, most families don't have any experience with anorexia at all. They have a child who comes to them who is usually doing pretty well in life. Most of these kids are the kind of kids that parents dream about, in theory. They are compliant, straight A students, driven to excel. That's the kind of kid who gets anorexia nervosa. In fact, I used to say, if they don't have straight A's, I'm really questioning if they have anorexia. And I still kind of believe that most of the time. Doesn't matter anything else about them. The drive, the absolute insistence on perfection is got to be there, and then it gets pushed in this particular direction. So parents are often confused as to how this kid, who is so perfect and been so good, can be so completely off course. And they need help with that. They haven't seen lots of kids with this problem. They haven't seen how they all have similar kind of features and act similarly. And they have their kid who they keep seeing as their kid. In fact, it's really hard. I don't know if any of you have treated this, it's really even hard for them to understand what's happened. A lot of times they can't even have really seen the weight loss. There's one family tells a story about this. A mother is talking about, well, they kind of knew their daughter was not doing that well, but when they had to go to the 8th grade graduation and they were sitting back in the stands away from her, and they could see then, oh my God, she's so much skinnier than anybody else. But they're so close up, they can't see it. Now, this doesn't mean they're pathology in them. This is something all of us are liable to do, and that's not see what's right in front of us, as well as something we can get perspective on. So a lot of what being an expert consultant is helping the family get a perspective on what this illness is and how it's changed their child. You as a therapist, as a baseline, need to know what anorexia does to a person's mind, body, and social life. Because if you don't know it, no one's going to know it in the room, because the parents generally won't know it. The stance is one where you're engaged using your expertise, but you're not trying to control things. So contrary to my analogy about pediatricians and wanting to kind of control the patient and give orders and stuff, this is really an example of a therapeutic stance that actually encourages just giving the things that family needs to know in order to help, not to make the decisions for them or to tell them what to do. That doesn't mean you don't give a lot, you're active. You're giving them a lot of information because they need to know a lot. Decisions are left to the parents. And the whole time that I'm working with a family, my first wish is for them not to be there 1 minute longer than they have to be. I'm not good for you after a certain point. You may need me for a little while, but after that, frankly, life is much better than me. And I want that sooner rather than later, if that makes any sense. So I'm always trying to support autonomy for the kid and the parents when they're ready. So how do you be a good consultant? You need to know the medical and psychological literature on AN. You really do need to know it and be comfortable with it. So you need to understand that we don't really know the cause. You need to know that there's some heritable evidence about heritability of the disorder. You need to know what happens to kids' thinking as they get sicker and sicker with the disorder. You need to know what happens to the body and the bones and the brain. You also need to help the family think realistically about goals, because they don't really have an idea about this. What's a reasonable thing to do? How much should she be eating? How can I learn these things? And this therapy isn't one that prescribes things. It promotes learning based on parents' skill bases, but they need information too. So you need to know that sort of thing. If you're doing family work in the conjoint format that I like to do and that most of the studies have used, you need to be able to engage everyone. You need to help the family anticipate that it's going to be hard. A J-curve is a business model kind of process where everyone wants the slope to go from here straight up here, but in fact, usually what happens is when you start something new, it goes down for a period of time like a J, and then it goes steeply up. So it's a J-curve instead of a standard slope. Families need to you need to help families anticipate that. Another thing is, it's hard to hear a lot of stuff at once, especially in a crisis. I don't know if any of you have ever had a child that's been sick and you've gone to a doctor or to a hospital and you're overwhelmed with worry and anxiety about this kid, and you say, "What did that doctor say? What was that nurse saying to me?" You're so worried, you're so overwhelmed. These families are frightened, and they're not in their normal state. And by the way, I would remind you that they're not in their normal state. So blaming them for how they are right now when their kid is desperately ill is probably not the best thing. There's a study that was done at UCLA by Margaret Stuber was the first author, where she looked at cancer survivors, pediatric cancer survivors. So she looked at them 10 years later. So these are kids who had had surgeries and chemo and been in isolation and had every horrific thing we do to cancer patients done to them. And 10 years later, they were survivors, and she wanted to know if they had post-traumatic stress symptoms or problems. So she asked them. But by some kind of weird fluke of thought, she also asked the parents the same things. And lo and behold, the kids didn't have it, but the parents did. Now, a good parent isn't going to be too surprised by that, because you try to protect your child from all that stuff, and you worry that anxiety for them, right? And carry it. So it's not really surprising, but it's a reminder that parents with a sick kid are in a very anxious and distressed state. You mostly wouldn't want your own psychological health to be considered as being representative at that time. Meaning, if I only interviewed you about your emotional and psychological health when your child is near death, you're probably not going to be at your most healthy on your tests. Yes?
Being that said, have you worked at any time with something like mindfulness-based stress reduction for the parents as well as the family?
So the question is a good one. We have not ourselves modified or added any kinds of mindfulness to the standard model. That doesn't mean some parents didn't start doing meditation or do things to support their own development of a better frame. And other clinicians have done this sort of thing. So it's not, I mean, I don't know, it might be helpful. Many times the therapist, and you'll see this, serves as the container for an awful lot of that anxiety, and that's one of the big jobs that the therapist has early in treatment. And you actually don't want to get rid of it at the beginning. You actually just want to make it productive. Does that make sense? Mm-hmm, mm-hmm. Unless it's just totally overwhelming. Daniel tells a story about not overwhelming with information that I like, about a patient that he had. Daniel, as you know, is a clear speaker because you heard him earlier today. He's articulate and succinct. At the end of treatment, he met with a family and they said, "Well, Dr. LaGrange, we've really enjoyed this therapy, but we thought you, at the beginning, we said, does this guy think we're like totally dumb? He keeps repeating himself over and over again, telling us the same things." And then we realized that he was telling us the same things because we weren't listening, or we weren't hearing all the things he was trying to say. And finally we did hear it, and we recognized that. And as a therapist, I like the idea of thinking that when we are remembering that when we're trying to communicate something to a family, just because we say it clearly doesn't mean it's heard clearly. And as a teacher, I hear this all the time. I thought I was really clear. How could you even have a question? I was so perfectly clear. Well, no, you have a whole different idea of what I said. And this is the same kind of thing with hearing. The other thing about this treatment that's been a pleasure as a therapist, there's absolutely no blank screen in it. You are joining the family in the dilemmas. You are actually right there with them each week, hearing about what they've tried, thinking with them about what solutions they might apply, and so on. That's a great pleasure as a therapist. There's none of this, sort of distancing business. It's really quite intimate in that way. We've talked a little about empowerment already, that the belief that every family has resources to bring to their kid. And one of the things I like to remind people of, if you want to see a bad outcome in a teenager, take their parent away. I don't really care what their parent can or cannot do. They may have a range of difficulties. Unless that parent is actually, going to harm them physically or something, basically a parent is your best bet in life, period. It starts from the moment you're born until probably you die, but it's particularly at least through adolescence. When we take families out of the equation, we are therefore really potentially doing tremendous harm. So we have to make that decision very carefully. Now, some families will take themselves out of the equation. So some people ask me, well, who would you not do this treatment with at all? And I would say, well, if the family says, I will not do it, then I don't see any point in doing it, trying to do it. I might try and talk them into it for a little while, but I'm not going to try. If someone tells me they're not going to do it, then they're not going to do it. Most of these families also have raised other kids. There's a few that are single-parent families. They have other successes. They have skills to bring. And as Daniel was talking about with his various buckets, full, half full, and scraping the bottom, there are resources in every family and skills in every family. And this therapy really, really leverages parental skills and the loving relationship, even if it's got complicated features, to bring about change. It makes it highly efficient. And I'll tell you a little story about this because it was so instructive to me when I was first learning the therapy. I went to London to meet with Christopher Dare, and I went to his office, which was a little cluttered, in the Maudsley Hospital in the south bank of London. And he was looking at a videotape of a family he was treating. And he said, well, watch it with me. And I was watching. He goes, I can't figure out what I'm doing wrong. They're not getting better. And just the wisdom of that statement, I can't figure out what I'm doing wrong. Not what's wrong with the family, not what's wrong with the patient, what I'm not doing right to help get this family moving the way it needs to. Such a wise man. And absolutely the attitude that you have as a consultant and as a therapist in this treatment. To empower people, basically, you have to do more listening than telling, and asking than telling. When we come to trying to think through problems, there are suggestions rather than orders, and information rather than instructions. There's a wonderful phrase that Chris Dare and Yvonne Eisler use, it's holding the family in positive regard. And this means support, not criticism. So all the time, and as I've confessed, not every family is so easy for me to love. There are harder ones and easier ones. So trying to find that positive regard is sometimes important internal work as a therapist. A lot of positive feedback. Then this is just good therapy generally. If you want to change behavior, reward works better than punishment. I mean, we know this. This is not new things. So helping reinforce the positive things families do. We use it when we need to get more specific, and there are families who aren't as creative. We provide examples from other families. We say, well, here's something the family might have done. They found this was helpful. Someone else found this was helpful. Do any of these ideas seem like they might be things you could use? So we might get to that level. And we do advise rather than prescribe. From narrative therapy, the notion of externalization by separating the illness from the patient is one of the core ideas in the FBT approach. And there's a bunch of reasons why externalization is an important strategy. One I already have sort of hinted at. For a parent who has a kid, it's hard for them to separate the kid from the disorder. They can't necessarily see, it's hard for them to see, when she's yelling about not eating that piece of toast, that's not her yelling, but that it's more a symptom of anorexia. It's hard to separate that. Now again, if you have any kids with any problems of this type, you would know that this is hard for any parent to do. It's not easy to know. And it is mixed up. So one of the things we really try and do is help families separate the illness from the patient. And we also want the adolescent herself or himself not to feel blamed either. Because often these kids feel bad about how they're affecting other people, even if they don't want to change. They may act very prideful and disdainful about other people's opinions, but they don't generally like to have their families and friends suffer. So if they're given a little room also by being seen as having an illness as opposed to making choices that they're bad choices, stylistic choices. By the way, this is one of those things that it goes back to agnosticism in a way. One of the reasons when Daniel says he's put up all the studies, and if you looked at those, there's the 5 of them, and if you added up those numbers, it's about 300 or 400 kids. That's in the world literature in a disease that was described in 1874. That is life-threatening and life-changing, for which we have almost no effective interventions, and which is very costly. How do we explain that? We explain that because people believe, or have come to believe, that it's a style disease. It's a choice. It's a lifestyle. And it's not that. I mean, if you think you can choose to be anorexic, you can't. I promise you, you cannot. You have to have a certain disposition to start with to get there. You can get worried about weight, shape, you can be uncomfortable and so forth, but to get anorexia, different matter.
When I was working with someone, I basically, in order to separate that blame to the student, as well as for the parents, because there's fear and anger and all of that gets very emotional. I said to start using the eating disorder as a person to actually personify this devil per se. Because there is so much along with the adolescent growth and the independence that goes on. And as you said, it gets very mixed up. So the parents started just calling it Ed.
Yep.
I'm fed up with Ed, so that they could bring it out. Eventually, the child made her own name up for it, so that we could separate this disorder from the actual child. Because once we were going to get past it, we had to rebuild that bridge that the eating disorder created between the parents and the child.
Right, so you've just illustrated externalization very well. That's exactly what you want and the reasons why you want it. And there's a lot of different strategies. These are some that we use. You use this ed idea. Daniel had earlier referred to a sort of model of cancer that this is like a cancer, that it starts off small with a dysplasia, and then it can become a tumor and it can become disseminated. So that's a disease model. There's this possession model we use sometimes. This is Daniel left the room, so I'll tell you about his anxiety about insects. He doesn't like them, but he has, like most people who are worried about things, they kind of are also drawn to them. So he watches those nature shows on TV, and there's these Amazonian spiders that live up in the arboretum of the rainforest, and the little birds are on the ground floating around trying to get little grubs and stuff. And these spiders wait, and then they pounce down on the bird, and they inject a venom. And anorexia is like that spider. And the only way that bird would ever survive is if someone goes and grabs that spider and takes it off. That is a very dramatic kind of externalization, but it is sometimes a very effective one for families who are pretty resistant to the idea. I have a very much cooler intellectual approach. I use the Venn diagrams. You remember Venn diagrams from? So you have this, here's the person with anorexia before they have the illness, is this regular kid. And then as they become more and more ill, their pattern becomes obscured and changed by anorexia as it overlaps. And their pattern is still, Venn diagrams have patterns, and you still see both patterns, but they're distorted by, the original person's distorted by this, and that's the family's seeing the distorted view. So that image of then separating the overlapping Venn diagrams is something that I use. I use genetics, as we talked about earlier, to reduce blame. You know, there's a heritable component, we don't know what it is. And I've talked a little bit about behavior and treatment process. The Venn diagram I've talked about, and the J-curve, but the sandhill, you guys have sand here, but there's no hills hardly. But have you ever tried to climb a sandhill, like a sand dune? And it's hard work, right? How is it that you actually end up getting to the top of a big sand dune? Huh? Somebody can help you, yes, that's right. But what do you have to do?
Dig really deep in it.
You have to dig deep. Yeah, but you have to do something else. You have to keep moving. If you stop, what happens? You slide down. So one of the things that, this is a mother of a patient who backed off too soon trying to help her child eat, and she slid back and she said, "This is like climbing a sandhill. I get it now. I gotta wait. I cannot pull back until we are at the top." And that is very important, and to me it was really insightful of her, and I've used it ever since as an important observation. So these are just some images for you. Look how big that spider is. Those are the Venn diagrams, and that's that J-curve. As I've tried to suggest, the treatment is pretty much early on focused on symptoms. And the symptoms are severe underweight, over-exercises, and occasionally binging and purging in the context of a very low weight. So those are what you're going to be working on in the therapy. It is so tempting to go off on 100 other directions in therapy, because behavior is hard to keep looking at, and yet it is what we know needs to change first. In the inpatient programs that have been done for 100 years, they're all pretty successful at getting people to change their behaviors, and that's what they do. They talk about doing other things, but they're actually pretty successful at getting people to gain weight and so on. What they're not successful, the reason they don't work, in other words, the reason that they don't cure people, if they cured people, I wouldn't be standing here right now. I would have solved this problem already. If they cured people, then just weight gain alone would be sufficient in changing those behaviors. But they only do it in the context of the unreal world of a hospital. Learning to be useful needs to take place in the environment in which it actually needs to be practiced. The reason family-based treatment works as well as it does and maintains the benefit, which is really the key point, is because you're doing it at home with your family in the context of your friends, social life, and school life. That's where you have to practice eating. And you cannot mimic it in an inpatient or day program. It's all a fabrication. And no matter how we try and minimize the artificiality of it, it's not generalizable. Therefore, the learning doesn't go anywhere. In terms of the behavior. You might learn other things conceptually, but at least in the context of certain things, I'm a little bit hesitant to say this since it'll be recorded, but I've become a little less enthusiastic about the benefits of insight changing behavior. I've seen too many people be able to be quite clear about what's going on and change nothing. Have any of you experienced that? So it makes you, as a therapist, it makes at least part of what used to be, what we thought would be helpful, a little bit less have the traction we might hope in terms of making change. And when someone needs to make the kind of changes that a kid with anorexia needs to make, I mean, they usually need to gain a significant amount of weight. They need to stop running, 8, 9, 10 miles every day, or whatever different exercises they may be doing. They need to stop throwing up their food. Those things cannot wait for insight to sink in. You actually need to get at them now. When we do the treatment, we also, therefore, are looking for behavioral change rather than insight. And our history, when we do in the therapy itself, is really on anorexia. We're not really interested in terms of, within the therapy, of a broader view. This means we delay and don't focus on a lot of other potential problems that might be fun to talk about or interesting. More fun to talk about and more interesting maybe, but not essential to changing anorexia. And in this treatment, there is no direct cognitive focus on weight and shape concerns or anything like that. And this has always been sort of one of those areas that I worried about, because we do in other conditions like bulimia really do work on weight and shape concerns in a cognitive manner very directly. But in family-based treatment, the idea is by changing the maintaining behaviors, the cognitions will diminish. And that seems to be what happens. So if we look at a trajectory of outcome, first we'll get weight gain, and then we'll get emotional stability, and then 6 months later we'll get cognitive change. So it's just important that it happens, but it doesn't happen the other way around, that you do the cognitive change first. How do you remain focused? In this approach, we use a lot of little strategies. One is we use a weight chart. Every week we meet with the family. We weigh the patient. None of this hiding the weights. We don't turn kids around. We don't put masks on them or anything. We tell them their weights once a week. We want them to know they're gaining weight if they are. We want them to know if they're not. We want their parents to know, so that they know what's working and not working. There's a lot of feedback that comes from that, and it sets the tone of the sessions. The other way that we remain focused is we don't look at etiology or causation, as we've emphasized, and we really do want to limit, as quickly as possible, the medical effects of starvation on the brain and the body. And one of the benefits of a manual is it helps keep you focused, because there's so many things going on in anorexia and a family and so forth. It's very easy to get pulled in many directions. A manual actually helps you. You don't have to think of it as a straitjacket. You could think of it instead, this is how I think of it, as a support system as opposed to a straitjacket. And what I used to do when I wrote the manual, I used to keep a little Post-it note with the main interventions on my clipboard when I went into the session, just to remind me to stay focused on the 5 things I needed to do. And these will be what we'll be illustrating in the afternoon. When you put these things together, we have a treatment that is focused on anorexia specifically, and it's staged in the 3 phases that Daniel described, and we'll get more detail later. Again, emphasis is on behavioral recovery rather than insight, and cognitive change happens later. But it does happen within the time that we can follow people. So it's not like it takes years. It's possible that by working on a difficult dilemma, that improves family functioning generally. The measures of family functioning available to us, I think, are pretty bad. So we haven't really been able to determine that there are changes. And everything about the treatment, as I said, is about getting them back into their lives. People ask me, how do people get well from anorexia nervosa? And I say this only slightly cavalierly, but I believe it really, that the reason people get better from anorexia nervosa is life is more interesting than anorexia nervosa and replaces it. So that the compelling focus and energy that you throw in, that this child puts into all the rituals and thoughts and concerns and around losing weight and getting lower and lower, that when that is no longer compelling and instead a boy or a school or a aspiration becomes something to pull them away, once you can kind of get that spider off and then those other horizons can be opened up, that's really ultimately how you get better. And that's why, and we're not life. I mean, as therapists, we're not real life. We're pulling the spider off part. Life is their friends, their family, things like that. Okay, so I think these are the books that are out there. We're going to talk about this after lunch. It's lunchtime. I think we have an hour break for lunch, so we'll come back here then. And we're only going to discuss the manual on the left, on your left, but there is a version for bulimia that's slightly different. So we'll stop now unless there are any burning questions before break.
I just have to ask, and part of that I think you addressed. But one question that came to my head is, so every young person wants to gain weight? That's my question. Especially, even though I know we said cognition will come later, but we also have the social media, we have that perfectionism kind of deal. Every young person wants to gain weight, question mark. And the other one is, like you said, life becomes more interesting, maybe the boyfriend, am I going to college, or these other things. And therefore, that almost replaces now, I am gaining weight because I see this weight chart and it says I'm gaining weight. Oh, eek, can I handle that?
Yeah.
As these other things are going on, but every young person wants to gain weight.
Yeah, so I went a bit too quick there. First of all, nobody wants to gain weight. It comes to my office.
I don't.
If you think those are the kids that come to my office, they go to Daniel's office. They never come to mine. They are screaming, howling, or hair down over their face, really not talking at all. Doesn't matter. They have anorexia. By definition, they do not want to gain weight. No, I don't expect any motivation. I don't expect any. But they're not psychotic. The realities of what's happening on their weight chart they need to actually see. It's not pleasant. It's hard. The family needs to see that actually because it helps them know, what, she's having this kind of reaction to gaining half a pound? Mm-hmm. What? And she told us she'd gained 5. She knew she'd gained 5, and actually she lost a pound. I mean, they learn. So they learn how she's thinking, they learn how she's feeling. That helps them externalize, helps them know they need to take action, things like this. So at the beginning, no, they do not want to gain weight. They never, I think, get to the point, or many of them don't get to the point where they really love that during treatment, but they accept that they will, have to, that no one's going to let them die by starving themselves to death. They're not going to let them destroy their heart and their bones. They're not going to let them wander around in this completely obsessional state around food and calories. That's got to stop. And so once that message gets conveyed and the behaviors are contained effectively by the family, that begins to set the stage for changing thinking. Because those, if you think about it, those behaviors the exercise, the starvation, the preoccupation, the weighing, all the things the kids do, the ritual around food, those things are actually fuel to the fire of the cognitions. And when you take that fuel away, this is an analogy, but when you take that fuel away, the cognitions don't have any fuel, and they begin to wither. And as they wither, there's room for some other kinds of things to come in there now. Because anorexia, when you talk about somebody, the kids, you talk to the kids about it, I've talked to so many, they don't know how it really happened. They sort of wanted to kind of lose weight a little bit, or they wanted to eat healthy, or something minor. And then they said, well, and I did it, and then for some reason I said, well, I can do a little more. And then pretty soon I just kept setting goals. And then it was lower, it was just lower, it didn't matter anymore. And then suddenly I really was attached to all this stuff. I didn't want to give it up. And I really liked it. I liked a lot of things. Now I might not have liked some aspects of it, like my parents hounding me all the time about eating and stuff like that. But still, I liked it. And so digging them out of that hole is step-by-step process.